It's okay. Here we go. And then I'm going to work on sharing my screen so that we can do the things. Um, all right. So I'm going to present this, and then Chris and I are really just going to engage in a conversation, as we often do, and talk about this really fascinating subject, which is ivermectin and fenbendazole in cancer care. Um, and the upshot is like for people that we work with, and even, for us as people that support people with cancer or as we live with cancer ourselves, um, is this something that we want to include? So I want to tell you a little bit about who we are. I'll just start and say I'm Amy Neff. I've got a picture here of myself and our my mentor, and I know Chris's mentor as well, Naisha Winters. We both have trained in metabolic and terrain-based approaches to cancer care, and it is the framework through which we work. Chris, tell us a little bit about yourself.
I wish now I would have put up my photo of me with Naisha, but I didn't.
Oh.
Uh, Hi, everybody. Some of you I know. I'm Chris Joseph. I'm an 8.5 year third stage pancreatic cancer thriver, and now a train advocate and also a radical remission coach.
Yes, and author of Life is a Ride.
Oh,
Uh,
Offer of Life is a Ride. Yeah.
yeah, yeah. So we are going to kind of talk about these two particular drugs in a comprehensive care model. And so just to kind of get started, we want to talk about what we're hoping to accomplish today. So one is to validate people's experience. I mean, why are people finding out about therapies like ivermectin and fenbendazole or mebendazole um, in the first place? And we'll get into this a little bit more deeply, but there's not enough trust. There's a lot of stories, and and people need to understand that, I mean, I personally believe that you have a right to try things. Um, and people are now empowered to do research on their own. We want to talk specifically about some of the details of these particular medications and maybe even introduce you to ways to finding out information about other drugs on your own if you're so moved. And then the legal piece. We're not diagnosing or treating or forming a doctor-patient relationship as a result of this conversation. So this is for information. And if it sparks your curiosity, we really want to fuel that curiosity and that sense of agency for you to do more. Um, so as I was doing research for this talk, I came across Vinay Prasad. I was not familiar with him. He's a practicing kind of traditional hematologist oncologist, and of course, his YouTube talk was about the crazy, ridiculous idea of using ivermectin or fenbendazole in cancer care. And he didn't really talk about why, except to say that it didn't work. But what he did say was this: when people see the establishment lie to them so many times, in the establishment, we are all creating the need for an alternative medical path and learning because we are doing such a shitty job. I was like, yes, he nailed it. Um, and he didn't actually, even as a practicing physician, provide me with enough information to close the door on these two drugs. He just frankly restated in his own way why people don't trust this system and voices in traditional healthcare. Any thoughts on that, Chris?
I know my own personal journey when I wasn't doing well early on, back in October 2016. I followed, like most people, the traditional Western medicine standard of care approach, and it didn't work. And it doesn't work for a lot of people. And so I think that's really a huge reason why people are getting online and social media, doing their own research. Some people are doing it out of fear, some out of desperation, some people frustrated. Yeah, I mean, it's the existing standard of care model too often fails.
Exactly. Exactly. And, frankly, I feel the same way about that, as in terms of my own education. You've probably heard that people in medical school get like one lecture on nutrition, you know, and yet it's so important. So here's my, like as we identify, like, why are we talking about these drugs specifically? It starts with people like Joe Tippins. So, I'll just kind of recap a little bit about him as a person and how he really kind of got the ball rolling for fenbendazole. So, a adult with non-small cell lung cancer who was in a clinical trial for people with late stage lung cancer, and the drug was Keytruda, and he was the only survivor of 1,100 patients in that trial. And he did combine the fenbendazole with vitamin E, CBD oil, and a liposomal curcumin. And then my own personal introduction to off-label drugs for cancer was through Jane McClelland, who has promoted not just the use of ivermectin and fenbendazole or mebendazole, but dipyridamole and doxycycline and other things. Any other stories, Chris, that you're aware of that have piqued your interest here?
I think you've captured both of them. I'm just thinking of the other drugs that Jane recommends. And I think metformin's on that list too, right?
Yep, and atorvastatin.
Hmm.
And what's interesting, if we go back to Vinay Prasad, he kind of ridiculed cancer study groups that are wanting to do some of these repurposed drugs. And at the end of the day, the literature on those repurposed drugs is kind of mixed. Like for metformin, for instance, it appears that most of the effectiveness in metformin to prevent cancer from coming back is in people who are already diabetic. Um, but what that doesn't mean that is that their drug's not useful. Just means that we have to be better about picking the right patients. Like just as in the same way that like Keytruda is not the drug for everybody, but for the people that it works well, sometimes it's like a home run. We definitely saw that with people with microsatellite instability and rectal cancer. Um, that immunotherapy was incredible. Um, so then moving on, people in in a cancer journey are often filled with fear. Um, you know, the kind of framework that treatments are presented to people just have a real way of arousing feelings. I don't know. Chris, you've sat there in the chair. Tell us what that was like.
Yeah, I mean, the only thing I was offered back then was chemotherapy. I wasn't a candidate for surgery or radiation. So it was chemo, take it or leave it.
Mhm.
And I did it and it didn't work. Um, and for those of you who've been on chemo or know about it, it's poison, toxic, it's very toxic. And I was feeling those effects. I'll say one other thing. I thought I was going to die of chemo before I would have died of cancer.
Mm. Yeah. Yeah. So, um, you know, f fear can breed innovation, you know. And I think that, I mean, my personal experience in helping my husband with his navigate his cancer was that for the first time in my life, I looked at the literature with completely different eyes, right? Because I had a mission. It wasn't just like, I mean, I love patient care and I'm often very attached to people, but when it became like a mortal question for a loved one that close to me, like I read things with a different kind of tone. And so in my husband's cancer journey, we used mebendazole because I was very convinced of the preclinical data specifically for colorectal tumors. And that leads to our kind of third point, which was that for me, it felt like an opportunity for us to take charge of a little bit more than what was being offered. Um, and so Chris and I think you and I both feel like when people have a sense of agency, like they're in charge of their health and all the rest of us in, kind of like in the gallery are supports, but we are not the drivers, right?
The number one thing I recommend to clients I work with, take charge of your health.
Mm.
Number one.
Yes. And then the last thing, which I alluded to already, is that there is evidence. So there are lots of preclinical studies. If you, when Chris and I were talking about this yesterday, I just did a quick question in PubMed. How many studies are published with ivermectin and cancer? And there's over 300 trials. These are preclinical things, but they're still like if we teach you how to go into PubMed and I as a practicing physician use PubMed to inform my practice, like what I'm offering to patients, then why would patients not, I mean, not idiots here, right? Like we can read. And so these are the reasons that we're talking about these drugs specifically. So let's talk a little bit about how Chris and I have been trained to think about cancer and to think about what we're going to do with cancer. This is going to be important when we look at the drugs themselves. So, cancer behaves differently than normal cells. And at this point, although I only list eight of them, there are now over 14 different hallmarks of cancer. And these hallmarks are essentially the differences between a cancer cell and a normal cell. And so we have cancer's ability to evade your immune system, which is why we put such an importance on immune system health. Cancer cells basically turn off the inner number of generations that cells normally are allowed to have. So baked into all of your cells in your body is a ability to divide about 70 times. And in cancer cells, that kind of natural lifespan or ability to divide goes away. So there are actually tumor cell lines that get studied that are considered immortal. And there's a famous movie and case about a woman named Henrietta Lacks, and her cells are called HeLa cells. So HeLa cells are the cells that are typically studied, in tumor biology. And so although she died in the 1950s in her 30s from cervical cancer, her tissue lives on. Um, and there's a really good movie about her. Avoiding apoptosis. So apoptosis is a Latin term that relates to cell death. So our cells, especially when they're not working well, have all kinds of mechanisms to cause them to die. And that's called apoptosis or apoptosis. And tumor cells evade that, they avoid it. Tissue invasion and metastasis, breast cells typically stay in breast tissue until they take on this ability to invade into the tissue and to spread. And that's where cells from one part of the body end up, in a different part of the body. Unchecked growth. So we have all kinds of mechanisms to just keep growth, at a minimum. And, you can have unchecked growth in non-cancerous things like a mole or a keloid or um, sometimes people get lipomas, little fatty accumulations. But for the most part, unchecked growth is a feature of cancer. Genetic instability. So tumors tend to evolve over time. They take on new mutations. They become like if they're treated with chemo, it can change the expression of DNA, cause new expressions, which then confer things like chemo resistance. And then tumors have this ability to, if they're hungry, they're seeking, uh, inputs, and they can grow blood vessels right towards them. And then reprogramming metabolism. So, outside of infections, which are the cause of cancers outside of the West, really, um, metabolic disorders are the main driver of cancers in the West, in Canada, Europe, the US, and the more developed parts of the country or world. And then here's the way that I'm sure most of you here have done a Terrain 10 questionnaire. So this is how we look at people from a variety of perspectives. And this gives us a direction to go in if we are trying to help people make decisions about where to place the emphasis in their health. So this includes inflammation, immune health, blood and angiogenesis, mental health, stress. I got a hormones, toxin burden, genetics, epigenetics, microbiome, and blood sugar balance. So um, we this is our drumbeat. Test, assess, address, don't guess. Okay. When people ask me if these drugs would be helpful, it has to come in some kind of structure because drugs interact with each other. Nobody has the same organs or ability to metabolize things. So this was our training. Um, it can the test, for instance, that we'll get into to monitor a person's tolerance or ability to tolerate ivermectin and mebendazole or fenbendazole are typically already done in most traditional oncology practices. That's a CBC and a CMP. Um, and that's just a basic level of monitoring that I feel and I know Chris feels is important to provide some structure. And then, again, deeper into it, there's just tons of different strategies for how to use these medications. So, any thoughts here, Chris, before we move into the drugs?
I mean, just under the paradigm of test, assess, address, well, I think people on this call may know this, but we are trained as advocates, as trained advocates, to be detectives. So we don't wind up guessing. So I can tell you when I was a patient and the doctor was interviewing me, she wanted to know about my history, my exposure to toxins. And that turned out to be a really, really important thing in my journey because I grew up in the San Fernando Valley, living in smog, horrible smog for about 30 years. My high school was across the street from a toxic dump that was spewing toxic fumes before these dumps were regulated. So yes, I mean it's all part of being a good detective to know why a person got cancer.
Yeah, and I think as we move into a conversation about the drugs themselves, I think what's important to say is if you don't look at your terrain and you just start to think, oh, I just need to take these, we might be missing one of the most important opportunities that we have, right? So as um as helpful as these may be to your particular situation, we want to make sure that we haven't ignored some of those big ticket items. Um, and a really important one, which isn't a lab test, is, kind of inquiry into one's mental health and, past history of trauma and kind of like the way that we can kind of hold those aspects of a person's well-being. I am really convinced of this having just, you know, done a big dive into the nervous system drivers of cancer, which would be completely missed if we weren't talking about it. And I know it doesn't get addressed enough in traditional oncology. So let's talk about ivermectin first. It's definitely better studied, has more actually current recruiting clinical trials. So I do feel like the system might be waking up to this potential adjunct in combination with some other drugs. So it's an antiparasitic drug. It treats lice, river blindness, heartworms. It's used topically to treat rosacea and other inflammatory skin disorders. Um, Depending on what information you look at, both ivermectin and mebendazole are some of the safest drugs that we prescribe, um, particularly in the antibiotic class. So I'm not saying that to say to you, I'm giving you carte blanche to like go take as much as you want and not monitor. But I think that you know, it is likely to be the case that if these drugs were causing a lot of side effects or adverse drug events, given how often they're being taken now, that that would be particularly juicy for the traditional medical system to kind of jump on and register a complaint about. So again, that's not saying too that there aren't some low grade signals that aren't being detected. But I do want to build a somewhat of a container of safety around this drug and the next drugs that we'll talk about. So people can have side effects from them, mostly related to visual disturbances, dizziness. It can cause some skin reactions. And then a big bottom line question mark is, these drugs have never been taken at the doses being prescribed for cancer for the duration being prescribed for cancer. So they're just some open questions because it hasn't really been looked at. Now, ivermectin uses a particular liver enzyme called the cytochrome P3A4 enzyme, and it blocks it. So if you don't know if you're taking drugs that use that particular enzyme, it's some antidepressants, it's Coumadin or warfarin. If you're blocking the metabolism of your warfarin, your blood could be really overly thinned. So, and bleeding is a major risk, from Coumadin. Most people don't take Coumadin now like we used to prescribe even 10 years ago, 15 years ago. Um, but it's just kind of an invitation for you to be curious about the other drugs that you take. There are lots of online drug interaction checkers that allow you to input all of your medications, supplements, everything, just to see if a major interaction comes up. Um, so we talked a little bit about both the cancer hallmarks and the terrain factors that we are looking at when we're thinking about treatment and supporting people. So when we think about terrain factors that ivermectin addresses, well, it directly impacts angiogenesis pathways. So it's limiting how a cell can feed itself. It's lowering inflammation. The particular pathway happens to hit is one called NF-kappa beta. It's a very potent anti-inflammatory pathway. For both ivermectin and mebendazole, they both appear to change the host microbiome in a positive way. So there's some speculation that that's actually how, or at least a significant part of how the drug's working in cancer is to alter the microbiome. Both ivermectin and mebendazole affect the individual proteins that cancer cells use glucose for energy. And then ivermectin appears to help cells turn on that programmed cell death tool. So the immunogenic cell death or apoptosis. So, just kind of repeating these things because our terrain factors are really closely aligned with cancer hallmarks. You can see here that there are just several different cancer hallmarks that ivermectin appears to address in non-human trials. So, what do we not know? We don't know how they stack up with other therapies. Um, there is a current study combining ivermectin with a PD-1 ligand targeted therapy. So, I think these things may show up soon. Um, and I really hope so because or ways for us to kind of crowdsource information from what people are already doing. What are your thoughts, Chris?
Do we know the efficacy of, say, ivermectin being used at the same time as chemo? Not only the efficacy, but the side effects of that combination?
Yeah, so no, is the bottom line. I think that it's just I mean, those are open questions. Every source, every resource that I looked at said we just don't know. And there are people that are definitely, I think, with some sense of authority saying you can take this with other chemos. And all I can say about that is we certainly don't have the clinical trial data. it's been done so many times now that I do feel like if there were a signal of a lack of safety, it might show up. However, you know, sometimes, one of the things to remember is that like when the FDA brings a drug to market, they power the safety data studies to look at an incident rate of about 1 in 10,000 patients or less. And so drugs are brought to market, then sometimes in the post-marketing analysis, we start to detect problems in the drugs. Okay, so um, you know, a good example of a post-marketing problem would be things like um, with the GLP-1 medications, there have been some issues with like vision, retinal disorders that have shown up with drugs like Ozempic or tirzepatide. It's not that common, but when you put millions of people on a drug, the incidence starts to become something people would like to know about before they choose to take a medication. So I think that's probably the realm that we're in as far as how often stuff's happening. But because it's not studied in some, open, well-designed way, we can't also say, I mean, there's some signals that I think more mebendazole can interfere with some treatment effectiveness. And, these drugs are typically being taken by people who have maybe more advanced disease. And so it could be that the signal is read as a treatment failure when it actually could be a drug interaction. Um, does that make sense?
Yeah.
Yeah. So then, um, and I think there's some remarks in the chat. Let's get through this, and then we should have plenty of time to entertain questions. And I really want to kind of facilitate a good conversation about this. So with mebendazole and fenbendazole, um, so these are two medications in the same category of antiparasitic medications. They're called bemidazoles. And mebendazole carries FDA approval for use in humans. Fenbendazole is not FDA approved for use in humans. Um, they are metabolized slightly differently, but the main difference between the two is that fenbendazole has a much longer half-life in the body. Now, whether or not that is a good or a bad thing, I actually don't know because we would have to have a study that kind of looked at those and said, we either want to pulse something or we want to press it for longer, in terms of dosing, administration. There's a lot of questions that come about just simply by the nature of the differences between these two drugs. Um,
Can you explain the half-life comment just to
sure.
people?
So half-life, which is measured in typically in hours, is so for instance, the half-life of mebendazole is pretty short. It's like 3 to 6 hours. And the half-life of fenbendazole is more like 10 to 20 hours. That is the amount of time that takes for your body to degrade half of the drug. So after 3 hours, you've metabolized 50% of the drug of mebendazole. After 6 hours, take that other 50% and cut that in half. So it's like every 3 hours, it's another 50% of the remaining amount is gone. So typically we say after 5 to 6 half-lives, the drug is totally out of the system. Okay. But it's incrementally, it's like, and then, kind of stair stepping down. So with mebendazole, there have been not many case reports of more serious problems, including elevations in liver function. And this is important for people to know if they happen to have already accumulated some liver damage, either through metastasis or medications or other liver pre-existing conditions with the liver. Um, I definitely would encourage anybody listening that has a child they're planning to treat with this to be a lot more careful. So seizures have been reported in children under 1, and I would just, say you'd want to be really cautious in children under 2. There's plenty of experience in using this drug, however, I mean, it's sold over the counter in many parts of the world to treat pinworms in children. Um, and then there has been one phase two trial. So phase two is usually looking at dosing. And so in a phase two trial in patients with advanced gastrointestinal cancer, these were people who had already failed conventional therapy and they were given 2 grams of mebendazole a day. And in about half of the patients, it was a very small study, only about 10 people, half of those people showed what they looked like hyper progression. So that it appeared that the treatment itself was causing the cancer to advance more rapidly. Um, as far as drug interactions are concerned, the most important one is just the combination of bebendazole with flagyl. So people with cancer sometimes get C. diff, and that's often treated with flagyl. And so if you were on mebendazole and maybe didn't feel confident in sharing that with your care team, you wouldn't want to combine that with metronidazole or flagyl. It increases the risk of this condition called Stevens-Johnson syndrome, which is basically like the biggest allergic reaction where the inside of mouth to anus lining of the digestive system, or external skin can just separate from the membrane below it. And it's very serious, very serious. Often people end up with that in the ICU. And then, yeah, go ahead, Chris.
Maybe you covered this and I missed it. So are there any studies that show Fenben or mebendazole with ivermectin?
No. And I've scoured the literature as much as I can. I think that there's plenty of biologic plausibility for why you might want to combine them. But we can't speak specifically to whether or not um, they work together well in humans. And this is just I mean, as a practicing physician, at the end of the day, I try to make decisions based on, you know, science, first of all. Um, and then, and then, like I said before, with my husband's cancer, with the rectal cancer, there was enough literature that spoke to these cancer hallmarks and terrain factors that made me feel, and then the safety profile of the drug that made me feel like probably a common feeling that you guys have. What do I have to lose? What do we have to lose? And even, a few years ago, there was enough anecdotal information about the use of this drug class from patients posting and from Jane McClellan's book that made me feel like, yeah, we probably ought to add to what we're already doing. Um, Yeah, and so this was kind of, something that Chris and I wanted to really make sure we emphasized was that for most of the people doing mebendazole and fenbendazole, it's not the only thing they're doing. And so there's a concept of just stacking treatments. Chris, how do you approach this with people when you first meet them?
Well, I will say that I get asked about these drugs all the time and more than ever. I had a client this morning ask me about dosage for ivermectin. And of course, I don't have the answer for that, nor am I legally allowed to answer that. Um, but can I read you a quote that I wrote for a paper I'm trying to get published on these two drugs?
I would love that.
So, and maybe this will lead into this discussion on the terrain approach. Relying solely on pharmaceuticals, even promising repurposed drugs, without addressing terrain factors is like extinguishing a fire while ignoring the flammable conditions that allowed it to ignite, meaning you still got to address the terrain.
Yeah, yeah. And I think that as a part of addressing the terrain, the other thing that we're hoping to do is help people be really alive to the present moment. It's one of my big critiques of conventional cancer care is that you just keep living kind of like from to the next appointment to the next appointment, kind of like not really remembering that like we're alive today, and like we want to make the best of it. And so, you know, self-care is hard, and that's part of our job is to kind of open a person up to doing this work. It's hard, you know, being along for the journey when it can feel stuck. Um, yeah, how do you do this, Chris? You've been doing this longer than me.
How did I do it personally?
Yeah, I
Let's
mean, maybe speak to the personal stuff and then what does it feel like to kind of work with someone, in encouraging terrain work?
Early on, I probably thought I was going to die, not dozens of times, not hundreds of times, thousands of times.
Mm,
That was the message going through my brain. I'm going to be dead within 1 year. And I made sure I surrounded myself with people who were really positive, who were supportive, who were rooting for me, um, who helped me believe when I didn't believe.
mm,
So that's one of the things that I try to do with clients is I'm really hopeful with the people I work with, really, really hopeful. I think they get enough negativity in a lot of the Western medicine system, and I do the opposite. We can do this. You can do this.
yes. Um, when we were chatting before, I think I was sharing with you that one of these trainings I did recently invited me to understand that people have to have a will to live. And I was reflecting back to you, Chris, that it's always so clear that you can see people's will to live when we talk about them. Yeah.
Yeah, I mean, back to my personal journey. I mean, I had some real strong reasons for living, which also, by the way, is one of the factors in radical remission, strong reasons for living. But my kids were teenagers when I got diagnosed. I wanted to see them graduate high school, which spoiler alert, I did. They're both in college now. There's many strong reasons for living.
Mm.
Uh, it's really, really good to tune into that.
Yeah. And then also what you've spoken so eloquently of before, which is about just this idea that you're thriving.
Yes, I mean, I'm clear that I am thriving, and I think you and I discussed this yesterday. I think the conventional cancer world has set the bar way too low when they talk about surviving.
Yeah.
That that's not good enough.
Right.
Not.
Right. Especially when success in some of the lanes of cancer care are defined as, you know, progression-free survival that might be a few weeks to a couple of months. And of course, the downside is horrible side effects, including literally, thanks to my new friend Vinay Prasad, in the package insert on sorafenib, it's like the loss of the will to live.
Mm.
Talk about a rough side effect, you know? Um, so so it's just a reminder, that foundational health, can't be neglected. We just I think we're both feeling like these drugs are very interesting. They generally appear safe. We feel like they need to be incorporated into kind of a more comprehensive model. One theme I often am bringing up too is that I appreciated so much in the early training that I did with Naisha about how you don't make good decisions when you're feeling reactive.
Mm.
You have to be grounded and resilient. And that is like a personal timeline. How long does it take you to move from reactive to feeling resilient? But there's a difference between feeling resilient and avoiding. Okay. So we have to make sure we understand that.
Could you explain that a little bit more?
Well, I mean, it just came from a conversation I had with a patient earlier who's trying to figure out if she wants to get radiation for, as a part of her treatment. And she was able to verbalize, I don't know if I don't want to choose because of fear and that I'm avoiding something that I actually need, or if I'm making a choice about something that I truly don't want. She can't quite figure out the difference of avoiding a decision out of fear or opting not to do something because she's more confident that she's able to navigate that without that particular treatment.
Mm.
Yeah. Um, so we're gonna just summarize here, a few points that we've made. One about defining success for yourself, and I think that one of the limitations in standard of care about defining success might be in just the quantity of time you have. And there's not a patient I've worked with yet that wouldn't define success as just being relieved of this illness, you know, of being and the trade-off might be we're managing it long term, but we mostly are not symptomatic from it. Chris, what do you think?
That's the way I look at it. I mean, I haven't had a scan for 3.5 years, and I'm not recommending that to anyone else, but that's just my own journey.
Mhm.
I haven't seen my oncologist for that same period of time. No one has ever told me that I'm in complete remission. The last scan 3.5 years ago was the tumor was about 25% of its original size, and that it could be dead tissue that was remaining. So
Mhm.
yes, I just feel like I'm managing it, and
Yeah,
I have zero symptoms.
yeah. And then how important is it to you that if you come across something that you feel like is going to benefit you, like that you are able to do it?
Well, let me give you an example. I think this will answer your question. Whenever I eat, I am very, very mindful now about looking at labels and thinking about anything I put into my mouth. And it really comes down to, is this bite of food going to help me or hurt me?
Mhm.
95% of the time, I'll do the health path. Once in a while, I'll still eat something that's probably not helpful because I'm not perfect.
Yeah.
But yeah, I'm very conscious of it.
Yeah, love that. I mean, I think that, as I kind of imagined this and I realized that, in my household's cancer journey, like we felt more empowered being able to personally adopt a treatment that had some biological plausibility for being useful. And and in that way, it felt like a empowering step. And it wasn't one that we had to ask our cancer doctor for. Okay. Now, like on my end, because I am a physician and have prescribing capacity, I could kind of like direct a lot of that for my husband in a way that a lot of people don't have the internal household like toolkit to do that. But this does end up being that for a lot of people. How important do you think that is for a person's ability to heal or have hope?
Ask me again because my train of thought was elsewhere. Ask me again.
Oh yeah. Do you think that being able to access drugs like ivermectin and mebendazole that feel pretty potent without having to get permission from the system of medicine is empowering to patients?
I do think it's empowering, and I totally understand why people are doing it, which we talked about earlier
Mhm.
in the discussion. But I do think that it's a much better idea to do it under the guidance of a doctor.
Yeah, fair. Um, so, the take-home points that we hope we made are that the validity of this treatment, I think, it still remains in question because there haven't been human studies. There's a lot of anecdotes out there. There are a lot of like we call them N of one trials where a person gets this and, has done better. And there may be ways, hopefully soon, that we can crowdsource information that give some better human biological basis to this. I always kind of refer back to medicine by theory tends to not go well. We had a theory in 1972 that a heart attack was a bleeding problem because when you did the autopsy on someone who died of a heart attack, there was a lot of blood and blood clot in their body. in their heart, in the blood vessels. And that same year, it was discovered that giving aspirin to someone having a heart attack reduced their mortality by 50%. It was like a coin toss of you're living or dying improvement. And it wasn't until 1986, 14 years later, that aspirin was implemented in standard of care treatments for acute heart attacks. Okay, so I always anchor that story of like, we can think it's a good idea or we can think something as one way, but our powers of perception are not there yet to understand something fully. Okay. In medicine, it's a science. We're always seeking the truth. We've never arrived at the island of truth. Um, so, and this is, I think it's personally important to me that to encourage people to understand that like the reason that people are seeking this out and I support it is that people are looking because what they've been offered so far does not feel sufficient. Okay. And so the usefulness of something is really the kind of the validity times relevance. So we don't know yet how useful this is going to be. Frankly need more data. If you're going to ask me a physician if these are useful, I'm going to have to tell you what we know. And I don't know how to interpret even my own patient's experience with it. But there are people that are taking it that are living beyond you know, the expected dates that their diagnosis would have said that they should be living. But I also know people are doing a lot of other things, you know. And at the end of the day, I don't think it's any one thing that's helping. So I have a few resources here. Anybody that wants, I'll stop my share and we can kind of open up the floor. Um, so I just invite you to let's maybe get into the chat and um, see what's going on here. But I invite you to just let me know and I can send out the slides via email. So Paula, yes, my husband did radiation and then he did um, Folfox, which is a combination of oxaliplatin and oral capecitabine for treatment of his rectal cancer. Um, and then Kathy, I heard recently that the formulation for ivermectin has changed and has two ingredients that are now harmful. So I have no idea about that. Um, and I mean, in the moment, I'm kind of tempted to just do like a little Google search and see what I can find out.
Where
Um,
did you do that, Kathy?
yeah, Kathy, you want to unmute and ask where you heard it?
Actually, I heard it on, it was an Instagram post this morning, and I thought that was very unusual, but it said something about two ingredients that were just added recently to ivermectin that actually create an opening for the blood-brain barrier to where it's sort of destructive. These two ingredients, I can't even remember, I should have written them down. But yeah, so I was just wondering if you had heard anything about that, because sometimes you don't know what you should trust on Instagram.
Yeah,
So,
absolutely. So, one thing I'll say about ivermectin and mebendazole or the bemidazoles is that it looks like if I were to read the tea leaves in the literature that they're looking for a patentable alteration so that they can start. I mean, just this is just how research happens and how drug development happens. The industry is doing this for profit. So ivermectin and mebendazole and fenbendazole are not patentable. They are old drugs. And so that's one of the reasons that they're not being studied as much is that nobody is going to be able to produce them and make a profit on it. And we've unfortunately pigeonholed ourselves to kind of require a certain type of information in order to advance those treatments into standard of care. Um, so, I mean, just a quick Google search what I'm seeing is that they've got some different formulations which are either designed to dissolve rapidly in the mouth, basically for pediatric use, or to improve drug delivery. Neither one of these drugs is super well absorbed from the gut. And so I think in cancer care, we kind of want them to be, nano drugs, liposomal formulations can be methods for those to be um, have enhanced absorption. But without, um, you know, clinical trial data, I couldn't tell you. I mean, it may be that just imagine it's like a poorly absorbed drug, then suddenly it's in a formula that's better absorbed, and your system gets,
COVID, the government was like,
hundreds of thousands of times more drug. Like that wouldn't be good because then your liver would be completely overwhelmed. Um, yeah. Let's see. Next question. Are you familiar with any studies combining ivermectin with doxycycline and vitamin C? Um, that, um, again, the only study I know of right now, which is currently recruiting, um, combining ivermectin with anything is ivermectin with a PD-1 ligand immunotherapy. Um, so, um, so no, I'm not familiar. There are studies. There was just a really big study looking at survival in people with advanced pancreatic cancer combining vitamin C therapy with chemotherapy, with gemcitabine, and it was really positive. So I really applaud places like the University of Iowa for advancing research for which there won't be a lot of money made. Adding vitamin C to chemo is not going to make anybody any money, but it clearly doubles survival. So I think that's great. Um, yeah, and then Chris, Paula's got a question for you about you saying that chemo didn't work for you, and so she wanted to know what did.
I'm smiling because it's one of the most asked questions I get, and I cannot answer it in one sentence. So I'll put my email address here in the chat, and people can email me and I'll send them. It's a long list of things I did. Um, I mean, coffee enemas, mistletoe, acupuncture, chiropractic, stem cell therapy, hyperthermia, supplements up the yin yang. I mean, it changed the way I ate, changed my life, went through a lot of therapy, lots of things, lots of things.
Mm. Yeah.
But I'm totally willing to send you the list if you email me.
Yeah, and then Margaret, you have a question about just rough dose ranges for ivermectin and fenbendazole. Um, and so the, you know, ballpark for ivermectin is about a milligram per kilogram. And then there's no studied like protocols. So some people do it daily, some people do it a few times a week, some people do this many days on, this many days off. Um, and I will say that's, about double the standard dose for treating infections. And treating infections usually involves like a single dose, or maybe 2 days in a row. So that's for ivermectin. And then for fenbendazole, Joe Tippins took 220 milligrams, 222 milligrams twice a day, 444 milligrams. And now there are protocols where the dosages again go way up with mebendazole. My husband used 4 grams a day. So 4,000 milligrams a day. Um, and um, and I think there are some studies, not studies, but protocols where people are using about 2,000 milligrams of fenbendazole, but not necessarily daily. So I think what you need if you're going to look at doing this, what I hope you can have is some kind of partner that, can anchor you and help you decide, you know, like what would probably work for you, and to make sure that you're not like Chris has said, like you're not just trying to do this and this only, because, again, I'm going to mention Vinay Prasad. One of the reasons that he said that these two drugs were not cancer drugs was because they themselves are not cytotoxic. Yeah, go ahead, Margaret.
Yeah, no, I totally agree. And I have, as far as the terrains go, working on all of the things, and I am working with a NATIA trained physician as well. And so I do have some dosing from her.
Mhm.
And we're kind of using it as part of the whole terrain field. The cancer is no longer there, but I have a lot of other autoimmune stuff. So those were very similar to the doses that she had recommended. So, truly appreciate your input and insight, and also just the management of the overall terrain is so important. So thank you.
Well, thanks for saying that and sharing that, Margaret. That's, it's great to hear it from us, but it's really validating to hear it from people that are doing the work. And congrats on cancer being in the rearview mirror. Um,
Thank you.
yeah. Um, and with autoimmunity, again, like rosacea, it's an autoimmune disorder of the skin. And isn't it interesting that it's okay to use ivermectin, in that setting? Um, yeah. What what other questions are coming up for people?
I'm not able to use the chat very well, or I'm just having trouble. But real quick, other than what I heard about someone saying the formulation of change potentially in ivermectin, is ivermectin, can we generally assume that the source doesn't really matter? Ivermectin is ivermectin is ivermectin.
That's a great question. So, honestly, I don't know. I would say that the drug industry already is complicated. We get um, a lot of our drug manufacturing right now is done in places that are not local, not in the US. And I think obviously just because of the work that I do, I'm aware of drug recalls happening all the time, where drugs are contaminated with carcinogens, with heavy metals that don't have the strength, either too much or too little. And I mean, I hate to say that to people because it just might make you suspicious of the entire the entire game, but I think there's probably a little less care given in the veterinary market, a little less oversight, although I'm not sure. Um, and I will say, perhaps this is somewhat cavalier of me, but I would say that at least in terms of the strength, the dosing strength of these two drugs, it's not a narrow therapeutic window. So what that means is that if if the drug you're taking is 20% stronger or 50% weaker, that's probably not going to cause you harm like other drugs for which the potency really matters. Does that make sense, Jim?
Yes, but what I was kind of also going to add, like if I'm receiving my ivermectin from a local compounding facility or something that we know is domestic or it's not made overseas or something, that would give me a little bit better reliability
Mhm.
um, expectation or quality control.
Yeah, I would hope so, you know.
Yeah. And Jim,
Um,
you haven't mentioned this, but I see on because I'm on social media a lot, and I see in these Facebook groups that there's actually a black market for these drugs, and I would be very careful about that.
Yeah.
yes, right?
But
Because
right now I'm looking at price, like it gets pretty expensive. So I'm actually just shopping it a little, but I
Mhm.
don't want to, just give up, just over a few bucks, but I want to, get a general ballpark of what I should be paying and not overpaying and not getting ripped off and making sure it's good stuff.
Yeah, there are, and I'd be curious, I could probably do a little bit of research on this. There are companies that you can submit chemical compounds to get like testing done It's actually done quite often in the psychedelic space. Um, and so I'm kind of curious about for this particular, you know, situation, if that could be done, a third party test on a drug. I think especially if you're anticipating taking it for a long time, um, it'd probably be worth purchasing a year's worth at a time and have, you know, if you get it quality tested, you know, kind of a lot number and a batch, a lot number and an expiration date, and you could get the company to confirm that they would sell you that lot number and expiration date, that it might be worth like a test or even forming a buyer's club to do that work and um share the results. Yeah, Michelle, Panacure is definitely the animal version. And then titanium dioxide and polysorbate 80, Kathy's got an update on what the ingredients were in the ivermectin. I'm kind of curious about if those aren't um, common components
They are.
anyways.
Yeah, I just looked that up.
Yeah. What'd you find out?
Exactly what you said. They're not uncommon. Used in many medications and supplements, found in vaccines, medications, foods. I mean, I guess it depends on the amounts.
Yeah, but I would say those are probably just the things that they use to get them in a pill form. And yeah, Paula, the cost, you know, again, $90 for a 30-day supply of a chemotherapy drug would be considered cheap, but when you're having to pay for these things out of pocket, you know, these costs can add up. And then Margaret, even if you're getting it from India, um, you know, probably the vast majority of the drug manufacturing is already happening over there. So the like getting it shipped from there like isn't crazy because we're probably like even our US like resellers are probably getting it made in India. That's where, you know, I just know from the drug recalls for things like blood pressure medications and diabetes meds that that's the story is that there's no oversight of of the drug manufacturing over there. Um, and so it takes a little while for the contaminants to kind of like get onto our radar. Um, frowning emoji. Yeah. Um, well, any other questions before we close it out? I really um I just really want to offer an appreciation of number one, just like how serious the topic is, right? Like the fact that we're having this conversation is like it's heavy and it's a reminder to me to kind of come back to the sacred space of like healing. And this is again, it's a phrase that I use that I learned from Chris very often about making sure that if we've extended beyond my toolkit, that I'm aware of where my toolkit ends and that my toolkit's not the only one. And I can apply that same lesson to, you know, every healer out there, whether it's the oncologist and we get to the edge of their toolkit or the acupuncturist and the edge of their toolkit. Um, and ultimately the patient who's the CEO of their own health. Like you have to be willing to get your own information. And if you've gotten to this point where you're curious about ivermectin or mebendazole, you're getting your own information. And I personally want to attest to the strength that I feel comes from your sense of agency in exploring these things. Um, so as you walk away from this, you understand what it's doing to your terrain, the limitations that there aren't really studies yet but the safety profile of the drugs is not bad. There are plenty of questions about sourcing and the quality that comes from those sourced meds, and that it's really there's no one treatment that's going to supersede the capacity of a comprehensive approach that's looking at why you got cancer and really kind of taking care of the low-hanging fruit on that front. Um, and if it ends up being that after looking at all of this stuff and listening to our talk and the other research that you've done, you come away with like a your sails full of wind to do this, um, then I just encourage you to find a provider that can support you in that, and and that you keep doing the work. Yeah, so one last question here. Liver enzymes, the main thing to monitor. Um, so I would say liver enzymes and blood counts, both of them. Yeah. And then also how you feel and other drugs that you're taking. So just remembering, just if you take away nothing else, just remember if I have to add a drug, I probably want to go to the drug interaction checker.
Carrie Ann, if you don't mind me asking, when you say over a longer period, what time frame are you talking about? Oops, you're muted. You can type it in the chat if you want.
Oh yeah, 3 to 12 months. Yeah, honestly, Carrie Ann, I would say something on the order of every, s- you know, probably month to 3 months, depending on what else is going on and other treatments, you know. Um, yeah, I'd probably divide and conquer and say every 6 weeks, at least while you're doing it to kind of have a sense of the stability of or the tolerance. So most medication side effects, adverse drug reactions are going to happen early in treatment. But that's not to say that, you know, if you weren't looking at any of these levels and they were declining, but you weren't aware of that, that's why you just need some regular assessments. And Paula, you had the comment, from Dr. Mankis about somebody curing their lymphoma. And, this is why we're here, right? When I looked at the several YouTube videos over the weekend, there were hundreds, if not thousands, of individual N of one saying, I did this and I'm better. And so if you're living with cancer, you can't ignore that. And you shouldn't, you know. And this is
I,
one complaint for our industry. Yeah,
yeah, I would want to know what cured means.
good point.
Dr. Neff,
Yes, ma'am.
this is Kathy. And
Hi.
hi, I just have another sort of a question for you just to get what your feelings are on this.
Mhm.
And since ivermectin and fenbendazole, they're sort of like antiparasitics.
Mhm.
I just wanted to know what you feel about addressing like a cause, and maybe some cancers are actually caused by parasitic activity in our bodies. And I want to ask you or tell you why I want to know.
Okay.
I had a very interesting thing happen to me where I had some health issues, and I took prednisone for a long time. I'm very holistic in healing. And what happened is that reduced my immunity so bad that I ended up getting invasive squamous cell cancers. I had 9 of them pop up all over my legs.
Mm.
And then they did biopsies on them, wanted me to go in and get Mohs surgery on them. And in the meantime, before I was deciding whether or not to do surgery, I did go to some nutrition response testers. One was a Chinese chiropractor, one was a nutritionist dietitian. Then I did go to an integrative doctor. And I had them test the lesions as to what caused it because I'm a huge, big believer in trying to find out what causes something to get rid of it. And they found that they were parasites. So instead of getting the surgery, I thought, well, I'm just going to go ahead and cure and get those parasites out of my body. And it's amazing because the integrative doctor had told me that for the parasitic, she wanted me to go ahead and start, ivermectin. And at that time, I just wanted to try to see more natural ways to do it.
Yeah.
So I did a parasite, which took, a couple months. And she also gave me a 10-in-1 essential oil to put on those sores. And a year later, they don't even appear on my legs anymore. They went away. So I just want to know if maybe because if ivermectin can work with some cancers, maybe it's because that is actually the cause of the cancer that needs to be addressed. I don't know. That's why I was asking you because you have more experience than I do. But that was just my individual awakening that.
Yeah, I love that question. So, there's a parasite kind of theory of cancer. And I think that there are some cancers that are definitely associated with infections in general. But Dale's correct. I mean, these drugs have kind of polypathway effects. So um, not just on like the microtubule formation, for instance, that mebendazole affects. Normal cells or cancer cells they use the microtubules to form their own scaffolding. So it just makes sense that it can have an effect beyond cancer being caused by an infection. Um, and it's also true that many cancers are infectious. Many cancers start or their trigger is a virus. Think about cervical cancer, think about head and neck cancers, think about lymphoma and Epstein-Barr virus. And um, yeah, so anyways, there's a lot there. There's also a really interesting kind of theory about cancer cells reverting to an identity that looks like an embryonic cell, the
Hmm.
trophoblastic theory of cancer. Um, so very, yeah, that aspect of tumor biology is really fascinating. And I think it's a place that we should mine for therapies.
Yeah. Especially if they're cheaper.
Oh yeah, that
Yeah.
and have fewer side effects.
Yeah.
Minimum. Yes. Well, let's close here. I bet we could all talk for hours. It's like my favorite thing. But let's wrap it up. And I'll also make sure that we have everybody who's on here an invitation to any future talks that we're giving about cancer therapeutics. We have a lot of ideas and also welcome and invite you to just throw some ideas out there if you want to hear from us about a specific things. Chris, any folding final words?
No, thanks for having me on. And I love that this is a group that pays attention, asks great questions. That tells me a lot. They're active in their journeys.
Mm. Yes. As you always say, you'll do well.
Yeah.
And you'll do well. All right. Thanks for coming, everybody, and I appreciate your time. Bye.
Thank
Cheers.
you.